Today we're going to be seeing a demonstration in this patient of a percutaneous lumbar discectomy at level 3-4, followed by a selective root block on the left side of L3-4, then followed by radiofrequency denervation of the facet joint L3 to L5, both sides. The patient is prepped with alcohol and then with iodine, and is given sedation with TCI, propofol, and 1 cc of fentanyl and 0.5 milligrams of atropine. And also the patient is getting oxygen through the nose. Here we can see the equipment by Arthrocare, which is going to be used for radiofrequency during the percutaneous lumbar discectomy. Here we can see the spinewand, and notice that the tip is curved in such a way that when it goes in, it organizes a tunnel by using the radiofrequency. The spinewand fits inside this needle, which is the one that's going to go percutaneous. So we introduce the needle you're seeing now through the skin, and the spinewand fits into it so that it can go into the disc. Once we're ready to start, we will start localizing the disc we want to approach by localizing it through the fluoroscope. We will usually approach the disc on the right side of the patient. We will count the level going from L1 toward the lower part, and in this case we're looking for L3. Once we localize the level where we want to, we will use a small stiletto to make a hole in the skin so that the needle can go in without too much problems. In this patient, we are looking for L3-4, and L3-4, also L4-5 is much easier to do than L5-S1, because usually L5-S1 is hid by the crista iliaca, especially in males. The needle is placed at the posterior part of the disc, and we verify its location by using a lateral and anteroposterior look with the fluoroscope. Once we're inside the disc, we will calculate how deep the electrode has to go in order not to get outside of the disc, neither on the anterior part nor on the lateral part of the disc. In the next couple of slides, you can appreciate there's a little spring on the electrode, which will be used to indicate how deep the electrode should go and not any further. Again, it's very important to verify in several planes that your needle, including when the electrode is at its maximum depth, is at the right position. Usually in the anteroposterior we try to more or less be in the middle of the disc, both inside and both sides and also in height. And if you're looking at the the lateral side, we also try to keep it more or less in the middle once the electrode is in place. The spinewand is now connected to the Arthrocare generator, the radio frequency generator, so we can start producing the lesion in order to cause a tunnel and to reduce the pressure inside the disc and some of the volume. We calculate that usually by doing at least 6 tunnels, you will more or less remove 2.5 cc's of material. After this slide, you can see in the movie animation where you can get an idea what is happening once the electrode is going through the disc. The radio frequency will break the water bonds in the disc, causing it to evaporate, and this is the way we reduce the pressure in the disc and also reduce the volume of the disc.
These discs, sandwiched between the spinal vertebra, are composed of 2 parts: a hard protective shell called the annulus, and a soft spongy tissue at the center, or nucleus. A healthy disc is like the shock absorber of an automobile, providing a cushion against jolts caused by simple movements like running or jumping. If the annular ring, or the protective shell of the disc, is damaged by injury or weakened by normal aging processes, a portion of the shell can give way to pressure from the spongy nucleus, causing a bulge outward. It is this unnatural bulge or herniation that often causes irritation to surrounding nerve roots in the spine, and the pain attacks that go with it. Decompressing the nucleus of the disc is a proven technique for relieving disc herniation and for treating the pain symptoms it causes. Disc nucleoplasty is a recent and significant leap forward in disc decompression therapy. Disc nucleoplasty uses a minimally invasive catheter to create an accurate 1 mm pathway into the disc. A micro-engineered alloy transmitter is introduced into the disc. Radio wave signals are sent through the transmitter into the jelly-like nucleus of the herniated disc. The radio waves produce a low-temperature ionized gas that breaks up molecular bonds in the spongy nucleus, dissolving tissue volume. When the injection procedure is complete, the transmitter is withdrawn. The removal of nucleus tissue relieves pressure on the disc shell, typically allowing the bulge to recede so that the disc no longer irritates.
At the end of the procedure, we will leave behind about 1 cc of a protein.